in-depth look at breast cancer screening. For those of you who are new to our organization, Breast Cancer Action, or BC Action, is a national education and advocacy organization that carries the voices of people affected by breast cancer to inspire and compel the changes necessary to end the breast cancer epidemic. We do this work through education, activism, and policy work. I said this at the beginning of the call, but my name is Kim Irish. I'm the program manager at BC Action. I oversee our Think Before You Pink and Milking Cancer campaigns and our policy and education work. Tonight you'll be hearing from the chair of our board of directors and the director of UC, who is also the director of UCSF's research group and think tank Advancing New Standards in Reproductive Health, Dr. Tracy Weitz. A couple of quick announcements before we begin. Dr. Weitz will be giving this presentation again on Thursday at 10 a.m. Pacific or 1 p.m. Eastern. And please stay tuned for our next webinar, which will be held in late August and will focus on gene patenting. You can look for details for the exact date and time on our website at www.bcaction.org. BC Action does not take money from any corporations that profit from or contribute to the breast cancer epidemic. Our work is largely supported by individual donors. Please consider making a donation today to support work like this educational webinar. Now finally, I just want to go over a few rules of webinar etiquette before we begin. The presentation of Sorting Out the Confusion, an in-depth look at breast cancer screening, will last about 40 minutes tonight. Then there'll be about 15 to 20 minutes for questions at the end. Everyone except the speaker will be muted during the webinar to cut down on the background noise to ensure that everyone can hear well. To ask a question, you can type it during the webinar in a pop-up box that should appear on your screen. We'll be keeping track of the questions and we'll do our best to answer as many as we can. But given the number of attendees, we may not get to yours. If we don't, please do email us afterwards at info, that's I-N-F-O, at bcaction.org, and we'd be happy to follow up with you. If you experience sound quality issues during the webinar, try hanging up and calling back in. Usually that'll fix the problem, but if you experience continuing problems, you can try calling webinar customer support. The number is 800-263-6317. We want you to get involved with Breast Cancer Action. This webinar is a great way to do that, and stay tuned for other ways that we'll mention later on. And now I'm going to turn it over to Dr. Weitz.
Thank you, Kim. And thank all of you for joining us tonight. I know that for some of you on the East Coast, this is a later time, but this is a really great opportunity, and the timing couldn't be better, I think, for many of us who are in the process of trying to figure out and sort through the evidence around breast cancer screening. Before I get into my talk today, I want to start by acknowledging that breast cancer is a deeply personal issue. Most of us at Breast Cancer Action, and I'm sure many of you in the audience, got into this issue because of a personal experience. And as a result of how we were affected by that disease, either personally or someone we loved around us, we had deep, very strong feelings about breast cancer. What we'll be discussing today about breast cancer screening may invoke and affect some of those deep feelings. I think what we all remember at the end, however, is that we're all trying to sort through the confusion. We may have differences of opinion, we may see things through different lenses, but we have a single goal of sorting out the confusion and making life better for women. So in the last 2 decades, women have received confusing, conflicting, and sometimes even politicized information about breast cancer screening. And if you're feeling confused, you are certainly not alone. Today's webinar is meant to give you more information about this complicated issue. We won't, however, provide any clearer answer than out there for many years, but we do hope to give you the tools to look through the science, understand the science, and as the science changes over time, to be able to interrogate and investigate that science. Beginning with one caveat, we also won't be able to give any individual advice about you and how you might make a decision about whether or not to have a mammogram. We hope to, however, give you more information and more tools. I thought I'd start by showing you a clip from the CBS Morning News that aired after the American College of Obstetricians and Gynecologists last week released their new guidelines. I think it may give us all an opportunity to think through the public dialogue on breast cancer screening and potentially give us some shared language as we move through the science.
Watch the mammogram debate. Breast cancer is the second deadliest form of the disease among women. Last year it killed 40,000 Americans, but there is still no agreement on how and when and how often to screen for it. On Wednesday, the American College of Obstetricians and Gynecologists advised annual mammograms should be offered to all women starting at age 40. 2 years ago, a government panel recommended waiting until age 50. So we're looking for some clarity on this life and death issue, and we get it from CBS News medical correspondent Dr. Jennifer Ashton and Nancy Brinker, founder and CEO of the Susan G. Komen Foundation. Great to have both of you with us. Obviously, a really important topic to so many people. And we have heard, Jen, guidelines changing and evolving. How have they changed and evolved over time?
Well, really, we were in front of this story, Rebecca, when it came out in 2009, and CBS really extensively covered it. The debate and the controversy, unfortunately, really continue to this day. So when you talk about recommendations, it really depends which organization is making those recommendations. If you break it down, ACOG, which as you said is the American College of Obstetricians and Gynecologists, and the American Cancer Society, they say start screening at 40 and screen every year. The National Cancer Institute also says start screening at 40. However, you can break that screening down a little bit to every 1 to 2 years. The U.S. Preventive Services Task Force, they created quite a stir when 2 years ago they said don't start until age 50 and then screen every 2 years. And again, these recommendations are for the women at average risk. The medical question is, how do you know if you're at average risk until you've actually been diagnosed with breast cancer?
And I think the question on everyone's mind, Nancy, is why can't they get together, pool their data, and come to one conclusion on this?
Well, we've had a conclusion for many years at Susan G. Komen, almost a generation. You know, screening saves lives. 98%. The 5-year survival rate for breast cancer diagnosed early is 98% in America today, largely because of screening and early diagnosis. People look at it differently. The Healthcare Prevention Task Force was highly confusing 20 months ago when they took this on, because they were scientists looking at data that most of us already knew. The point is, what do you do about this? And today, the announcement from ACOG, from the American College of Obstetricians and Gynecologists, 50,000 of them, goes a long way. These are treating physicians who are treating people, and most people in America are treated in their own communities, not even in cancer centers and places like that. So we need workable recommendations. Also, mammography is not 100% perfect. It should be. We have the ability to make it perfect in the United States today. It's political will. You know, it should be more accurate.
So you say it's politics that
a lot of it is
becoming more accurate?
Political will, not even politics. If you show political will, something happens. If you walk through one of the screening machines at the airport, they can almost see what you're eating. So therefore, I can't be convinced that better screening and better technology, and that's the position we took 20 months ago. But the issue is it does work, and it works in a broad population, and people are living longer because of it. Even though they haven't done the studies to say who's living longer, the fact is we know it works.
Jen, I want to get to you on how to reduce.
So, thinking through this clip, I think we have a pretty good idea about what the public dialogue is around mammography. What I hope to do in the next 40 minutes is interrogate some of the basic assumptions that are sort of presented in this clip and perhaps dig a little deeper into the science and what the science actually says. So if I think about this clip, I see 4 basic assumptions being made. The first, of course, is that the scientists should be able to come together and come up with a single best answer. We long for a set of guidelines that are consistent and that last over time. The second assumption in this clip is that early detection is the necessary component of saving lives and the reason that we have had a reduction in mortality in the United States. The third assumption is that more is better. If some mammography is good, then getting more and getting them more frequently is a better idea. And the fourth is that the problems with mammography can be solved through better technology. So I'm going to take apart each of these 4 assumptions, and that I hope when we get into questions and answers, what you see in this clip and what I don't address in this talk, we can talk about also. So let's think about this first assumption. The first assumption is that the scientists should be able to come together and come up with one best answer. So what did we have? We've had the American Cancer Society recommending at 40 every other year, the U.S. Preventative Services Task Force then coming and saying beginning at age 50 and every other year, and then some breast cancer groups endorsing that. The American College of Obstetricians and Gynecologists providing another guideline, the American College of Radiologists concurring with that but disagreeing with the task force, and of course what you heard here is that other breast cancer advocacy groups that are encouraging women to get them early and often. So, who's right? Before I go there, I wanted to talk a little bit about the history of whether or not the question about mammography for women in their 40 to 49-year-olds has ever been that clear, and whether or not we're not just having the same debate we've been having for many years. So let's remember that between 1978 and 1997, there were a significant number of scientific reviews that were completed, and almost none of which found any support for routine mammography in women aged 40 to 49. Now here, remember that we're talking about screening mammography. And screening mammography is something that we do to healthy populations. This does not include women who are at high risk, either because of their history of breast cancer themselves, or a genetic indication for breast cancer, whether or not they've had chest radiation and therefore are at higher risk. We are talking about asymptomatic women, that is, women who don't have any symptoms of breast abnormalities, who are otherwise healthy and undergoing routine mammography. So for 20 years, we had this sort of scientific evidence to suggest that there was no support for routine mammography in this group. In 1997, however, that sort of conclusion entered the political realm. And the U.S. Senate, who decided it was within their purview to vote to ask the National Cancer Institute to recommend screening between 40 and 49-year-olds. So at a vote of the U.S. Senate, the National Cancer Institute, which had this sort of understanding of the complexity and the lack of support for routine mammography from 40 to 49-year-olds, changed its mind and began to recommend that. In 2002, the National Cancer Institute, wanting not to be and continue to be involved in the politics of breast cancer screening, punted their decision to the U.S. Preventive Services Task Force, who again recommended individual decision-making for women 40 to 49. Now, we often understand this 2002 set of recommendations as recommending screening for 40 to 49-year-olds, but the real focus was on individual decision-making. What happened that brought that 2002 into question was in 2009, the U.S. Preventative Services Task Force reviewed the data again and decided to downgrade the recommendation for screening for women ages 40 to 49 from a B to a C recommendation. That is, they concluded that there was not evidence to recommend routine screening for women aged 40 to 49, but rather that individual decisions should take into account patient context, including patient values regarding specific benefits and harms. Now, people have interpreted the U.S. Preventative Services Task Force recommendation as saying that no women between age 40 and 49 should get mammography. That is, in fact, not what they said. What they said was that they didn't recommend routine screening, that is, that all women should be encouraged in these age range should be encouraged to get mammography, but rather that mammography, because of the risks and benefits, should be left to individual decision making. They also made two other recommendations. They changed they recommended, instead of an annual screening, a biannual. That is, that women beginning at age 50 to age 74 would be best served by getting their mammograms every other year as opposed to every year. And I'll talk about the science that led to this. This is distinctly different than the American College of Obstetricians and Gynecologists, who are now recommending that women have mammography every year. And we will talk a little bit in a few minutes about the differences and why one group might suggest 1 year and one group might suggest every other year. They also said there was insufficient evidence for screening women over age 75, and so they left that without a recommendation. So this is again brought to a head this month when the American College of Obstetricians and Gynecologists made a recommendation that, based after their review of the science, based on the incidence of disease, the sojourn time, that is the time it takes for things to grow, and the potential to reduce breast cancer mortality, the American College of Obstetricians and Gynecologists recommends women get mammography for 40 to 50, from 40 years older, every year. So, why did they come to such different conclusions? Now, I would suggest that all of these bodies are looking at the same evidence, but depending on how they weigh the harms and the benefits, and to whom they weigh those harms and benefits, their conclusions are different. So we'll talk more about these harms, these differences in benefits and harms, as we interrogate the second assumption that's included in the CBS clip that I showed you earlier. That is that early detection is necessary to save lives. So this way of thinking about breast cancer is somewhat outdated. It comes from an old way of thinking in which we understood breast cancer as a single progressive disease that starts not so bad and gets worse over time. And based on that, we decided that if you could go back in time and find breast cancer early, you could eradicate it and therefore stop it from killing anyone. And so based on this belief, we adopted an approach that early detection is the best way to save lives. And early detection, when cancers are smaller, leads to better prognosis. But years of breast cancer research have suggested that there is no single breast cancer disease. Rather, breast cancer is a complex set of diseases that all behave very differently. So breast cancers we now know are more complicated. Not all breast cancers are alike. Not all breast cancers can actually be found. Not all breast cancers can be cured. Not all breast cancers need to be treated. And that the type of tumor may matter more than the size of the tumor. And with this more complicated understanding of breast cancer, we've had to challenge the idea that early detection is what is leading to reductions in mortality and that early detection always saves lives. And it has then led us to think through what the risks and benefits are from screening and treatment. So Barry Kramer at the National Cancer Institute has given us a different way to think about breast cancer, which allows us to think more in a more complex way about who might benefit from mammography and who might be harmed from mammography. So in his typology, there are three types of breast cancers: turtles, bears, and birds. Turtles are non-aggressive invasive disease, and most DCISs fall into this category, that will never be life-threatening. That is, while you have a cancer, it is localized and never metastasizes to actually threaten the woman's life. Now, bears are breast cancers that respond to currently available treatments. They grow slowly, and then when they wake up, they can be deadly. So here the goal is to catch them before they wake up and to treat them before they kill the woman. But there are also birds. These are very aggressive forms of breast cancer that no matter how small we find them, we cannot effectively treat them. So when we think about cancer as birds, bears, and bees, we start to think differently about screening and potential treatment. So here is a graphic representation that Laura Esserman has presented that try to give you some idea about how we might understand diseases. So the turtles are the lower diseases. They sort of creep along and they maintain in this localized to the organ area. That is why they never harm and they potentially may not need to be treated. These bears that have a slow time and then they have a wake-up time when they go from localized to metastasized diseases. And then the birds, which have this very quick trajectory towards metastases and therefore aren't necessarily opportune for identification during screening. The problem, of course, is that we don't currently know how to tell the birds from the bears from the turtles. And we are looking through mammography at all three of these and calling them all breast cancer. So before I talk about the harms of breast cancer screening, I think it's important to remember who is helped by breast cancer screening and thinking through why the American College of Obstetricians, the National Cancer Institute, the American College of Radiologists, the American Cancer Institute, and the U.S. Preventative Services Task Force might have looked at the same data and come to different conclusions. This is a table that was presented in the U.S. Preventative Services Task Force, which provides a pool relative risk for breast cancer mortality. Breast cancer mortality is, of course, the death from breast cancer. Relative risk is what the benefit is from screening. And what you see here is the relative risk. There's a 15%, that is 1 minus 0.85 that you see here. 15% relative risk of reducing, of mortality reduction for both women in their 30s to 49 and their 50 to 59. So very similar in a sense, benefit from mammography from a perspective of relative risk. From this interpretation of the data, a group like the American College of Obstetricians or the National Cancer, the American College of Radiologists would argue that women in both of these age groups have the same benefit of benefiting from mammography, and therefore we should make the same recommendations. By comparison, the U.S. Preventative Services Task Force said it's not just about relative risk, it's about absolute risk. Now remember that the chance of getting breast cancer increases with age. So the older you are, the more cases of the disease there are. So what absolute risk is what the individual risk of breast cancer is. I'm going to give it just a basic math lesson here to try to make some sense of what I mean by the difference between absolute and relative risk reductions. So let's assume something that is 2 in 100, and it goes from 2 in 100 to 1 in 100. Now the relative risk reduction in this scenario is 50%. That's a huge benefit. So if I said you have a 50% chance, less chance of dying of a disease, you would think that is a significant reduction in the relative risk. But in the absolute cases, the relative risk is only 1%. So you could see how, depending on whether or not you're using relative risk or absolute risks, you might make a different conclusion. So let's apply this to mammography for women in their 40 to 49s. We know, as I said earlier, that there's a 15% relative risk reduction in mortality in dying of breast cancer. So the 5-year risk of dying in this case would be 4 for 1,000 women. And if you think about the number of women who are screened who will die, you will get an actual reduction in the number of women. But if you calculate that across the population, you'll see that 10,000 women need to be screened for 5 years in order to prevent 1 additional death. So what the U.S. Preventative Services Task Force concluded was that because there are more breast cancers for women in 50 to 59-year-olds, as opposed to women who are 40 to 49-year-olds, even though they share the same relative risk reduction, the additional harms that might be incurred by the population that has a greater number of women who need to be screened but may not benefit from being screened suggests a difference in the age-adjusted recommendations. It's different than the American College of Obstetricians and Gynecologists that make a recommendation based on the relative risk reduction being the same across these two groups. So clearly we know that some women do benefit from breast cancer screening, but all those harms that we weigh against the potential benefits of mammography that lead some people to decide not to have mammographies themselves, and some groups to decide not to recommend mammography to certain age populations or to certain groups. So what are the harms of breast cancer screening? Well, of course, the first harm to breast cancer screening, to remind us all of, is that there are false negatives. The screening test is not absolutely effective, and we may miss the presence of cancers even though a cancer is present. And this, of course, can give some patients an inappropriate sense of security. That is, you can believe or think that you don't have a cancer when you do in fact have a cancer. So mammography alone is not enough of a guarantee that a cancer will be found if it is present. For some women, that false negative, being told you were cancer-free on your mammography, may lead women to ignore other kinds of symptomatic activities in their breasts because they feel like they've been told they are cancer-free. So we always need to remember that a diagnosis of a negative mammogram is not the same as a diagnosis of no cancer. The second harm that many groups are concerned about, and certainly at Breast Cancer Action we are concerned about, are false positives. That is, you get a mammography, it indicates that you might have cancer, but you eventually turn out not to have cancer. So what's the harm of false positive testing? Well, the harm of false positive testing, I'm going to go to my next slide, I'll come back to this one in a second. The harms from false positive testing include things like discomfort, cost, inconvenience, and harm to the individual woman. Now, those could come from the test themselves or from follow-up imaging. In other words, you get a diagnosis of a potential cancer, you need to go in, you need to get a biopsy, you need to get additional testing services, and those testing services can have cost and inconvenience. Now, some people don't think that these are at all risky, and individual women may say that they don't care how many false positives they get. For them, they just need a rule out, and so there is no, in a sense, harm. But for other women, these have been found to increase both women's anxieties, as well as to create systems where women engage in prolonged surveillance for diagnoses that they never had. So women who are otherwise considered healthy now go about their lives entertaining and being followed over time as if they are potential cancer patients. And those can have real psychological harms for some women and can be very disruptive to women's individual lives. Now, individual groups have decided that these are more or less important, but at Breast Cancer Action, we believe that false positive testing and the effects of false positive testing are real, and that individual women need to take these into account when they undergo mammography. The other reason we care about false positive testing is there is some limited evidence, although not strong in the science yet, that biopsies, unnecessary biopsies, may in fact themselves be a risk factor for future cancers. And of course, there is the cumulative radiation risk from undergoing testing you don't need. And I'll talk a little bit more about radiation in a minute. The other thing that's important to remember here is that false positive testing doesn't occur the same in all populations. And this is part of what went into the U.S. Preventative Services Task Force recommendation of a difference between women in the 40 to 49-year-olds and the 50 to 59-year-olds. Here, as you can see from the modeling they did, that false positive testings are more common for women in the younger years, and that the estimated risk of false positive testing after 10 years, that is, if you get an annual mammogram between age 40 and age 49, can rise to almost 50%. That is, that if you start in your 50s, if you start in your 40s and you have a mammogram every year for 10 years, the likelihood that you will have at least a false positive is half. So that's pretty impressive as a statistic, and for some people that suggests a reason either to have less frequent mammography or to wait and defer mammography till a later year. In the U.S. Preventative Services Task Force analysis, they also found that most false positive results could be reduced if screening were started at age 50 as opposed to at age 40. Now, people have hoped that, of course, the move to digital mammography as opposed to film mammography would reduce that false positivity and give us better rates. But there appear to be comparable false positivity rates, although different technologies, film versus digital, work with different populations, and you may choose, and women may need a film versus a digital mammography depending on other kinds of things. And digital mammography may be a little bit better for dense breast tissue. But it doesn't solve the false positivity rate to move, unfortunately, from film to digital mammography. So false positives are an important potential harm to put into the calculus when we make a decision about whether or not any individual woman would want to have a mammogram. The other harm that has come and was definitely addressed in the U.S. Preventative Services Task Force and has gained more attraction and attention in the last year is the question of overtreatment. Now, overtreatment has come to be of interest in part because of our new typology of understanding breast cancer. So for birds, overtreatment means that women are treated, they become sick, and they're not helped by the treatment. In other words, we diagnose something, we treated them, and it didn't help them at all, but they did undergo all of the harms associated with treatment. It's also the turtles. These are women who would otherwise be considered healthy patients, who are turned into cancer patients and do not ever benefit from the treatment that they undergo. So why care about overtreatment? We care because many women who are diagnosed with breast cancer are being diagnosed with diseases that don't need to be found. And I think for anyone on this call who has themselves been affected by breast cancer or who has someone around them that has been affected by breast cancer, we know that treatments for breast cancer are not neutral. And turning otherwise healthy women into cancer patients during the prime of their adult life can have devastating effects to the rest of someone's health. Now I show you here another slide from Laura Esserman's work that suggests that we are now seeing a rising percentage of the breast cancers being diagnosed that are in this localized condition. We have seen very little change in what we're diagnosing at the metastatic and the regional. Those are the bears and the birds, and a big rise in our diagnosis in turtles. So if we're diagnosing more turtles, and turtles are problematically being overtreated, we need to rethink whether or not our recommendation that all women receive frequent and early mammography is in fact in the best interest of all women. I show you here a rise in DCIS. So not all, of course, DCISs are turtles, but many are. And when you look here, you could see that we have a huge increase in the diagnosis of disease that may not, in fact, need to be treated. And it may be that more women are being overtreated unnecessarily. I give you this slide to help us try to complicate the Screening Saves Lives story. So what you see on the left-hand side is the screening rates by racial ethnic groups for a 10-year band in the United States. And what you see on the right-hand side is the mortality rates associated with those same racial ethnic groups. Now you can't compare these, of course, because someone who's diagnosed in a particular year is not likely to get cancer and die in that year. But I think what these trends suggest is that while we have very comparable rates of screening in some populations, we have very different rates of mortality in those populations. And so screening saves lives, screening reduces mortality. While we know at a population level there are some benefits to screening in terms of reduction in mortality, it may not be that the screening is the only answer and the only explanation for the reduction in mortality. And in fact, the new efficacy of treatments and the way in which we now can type some diseases and treat some breast cancers much more effectively may be also contributing, or definitely are contributing, to the reduction in mortality. I'll just highlight a little bit more about African American women. An area that is of deep concern to the Breast Cancer Action is that last slide. The question about why African American women have lower rates of incidence of the disease and significantly higher rates of mortality. And I'll come back to this a little bit when we think about what we should be paying attention to at a research and advocacy agenda within breast cancer. So what we know is that African American women have higher rates of disease, they have higher rates of earlier disease, they have different kinds of breast cancer tumors. At Breast Cancer Action, we're concerned and interested in differences in environmental risks that may be contributing to different diseases. But the increased rates of mammography in this population have not led to a corresponding reduction in mortality, suggesting that mammography may not be the solution to the higher rates of mortality in this population. One last harm that I'll discuss here is radiation. I think what's presented in this cartoon gives you some sense of what people are concerned about with too frequent mammography. Now we know that radiation is, of course, a risk factor in breast cancer at high doses. Women who have had chest radiation are at higher risk of breast cancer and need a different kind of surveillance. But that higher risk gives us some question about whether or not cumulative low risk might be of concern, especially given that medical tests as a whole are increasing the radiation exposure and that to date there are no current limits for what is a safe level of radiation exposure on the individual level. Now this slide is very complicated and provides a little too much information. But what the conclusion suggests here is that we are uncertain about there is potential risk associated with mammography that may be cumulative over time. And so starting early and doing it too often for those people concerned about radiation risk may be a real concern. So how do I put all these pieces together? I think we balance the risks and harms. We know that mammography is not always the best tool. It finds cancers that shouldn't be found. It finds cancers that we can't do anything about. And care are about more than mammography, and that let's not throw out the baby with the bathwater, and remember that mammography done at the right time can save some women's lives, but that it is not without its risks and its benefits. So I come back to this slide to give you a chance to think about how you weigh those individual benefits and those individual harms. And you might now understand while individual groups looking at the same science may come to different kinds of conclusions about what they would recommend to women and what they would recommend to their providers about what to recommend to women about when to start mammography and when not to start mammography. So I go on to now to assumption number 3, which is that more is better. That is, if breast cancer can find something early, if we do it more often, we'll find things earlier, and that will be helpful. So every year or every 2 years? This is the question that the ACOG and the U.S. Preventative Services Task Force policies distinctly disagree about. Now, ACOG says that because the time to develop the cancers is shorter in younger women, that is because it's probably more aggressive disease, we should screen more frequently in order to find interval cancers. That is, cancers that develop in the interim between one mammography and another mammography. Again, now this is based on assumptions about disease progression and that the idea that those diseases can be interrupted if in fact you diagnose them early. The U.S. Preventative Services Task Force, however, found that in their modeling there were increases in harms, thinking back to that question about false positivity, and there was no additional benefit. But they are clear in their guidelines to remind the reader that these are based on modelings, and to date there have been no randomized controlled trials of periodicity. That is, we do not know from a randomized trial whether or not every year or every other year, and both groups are making recommendations based on how they read the science and how they weigh the benefits and the harms. So what's the harm from increased frequency? Well, I talked about earlier the greater risk of false positivity. I talked about the greater risk from radiation exposure. I haven't talked at all about the higher costs. Now, the U.S. Preventative Services Task Force was criticized widely in the public for being concerned about government costs. I will remind the viewers that the U.S. Preventative Services Task Force is in fact precluded from examining costs. And in fact, they did not look at costs. But there have been some studies, not the U.S. Preventative Services Task Force and not the ACOG recommendations, that have looked at the cost for mammography and found that the significant costs associated with frequency of mammography without an increase in benefit suggests why health providers and health plans might go to less frequent mammography. There also does not appear to be any increased detection of the bears. And I return us now to the slide that I showed you earlier. So what you see here now, I hope, is that sorry about that. The cancers that benefit from screening are likely to be the cancers that develop over a 2-year period as opposed to those that develop over a shorter period. So we may be missing cancers in the interval period, but those cancers may not be the kind of cancers that we can treat. So the last thing that's come about in the literature in the last year is whether or not mammography might serve a different kind of tool than screening. That is, whether or not mammography itself might be a risk assessment tool. We now know that breast density appears to be a risk factor for breast cancer, and that mammography can diagnose breast density. It can say something, assess some sense of breast density. And so if mammography can identify breast density, Can mammography not be a tool for diagnosing cancer in these cases, be a guide for determining how frequent and what type of screening women with dense breasts should get? This is the point of the most recent California bill, which requires that mammogram results now indicate breast density on their findings. The authors of this work, and in particular I pick out Erlikowski, are clear that while this offers some potential benefit for personalizing the breast cancer screening regimens, it is not yet ready for prime time, and no recommendations can be made. So I'll go now to assumption 4, the idea that the problems with mammography can be solved with better technology. That is, if we just had the political will, we'd create a technology that would solve the problems that I identified earlier, and we would be out of this dilemma about when to start, how often to do, and what to recommend to women. I'd like to suggest that unfortunately there is no political fix to our problem. That all screening modalities, because of the nature of what they do, that is, they are looking for a particular presence in an asymptomatic, otherwise healthy woman, will always have the same kinds of problems. Whether these modalities are clinical breast exams, breast self-exam, ultrasound, MRI, or thermography, the lower of which may provide some way to help get through the morass of mammography when used as an adjunct diagnostic tool. But they all suffer from the same thing. All screening modalities will have false negatives. All screening modalities will have false positives. All will diagnose diseases that may not turn into something that would kill you. All will diagnose things we don't yet have effective treatments for. Now, shifting to other modalities may reduce the risk of radiation, which is of concern to some with regard to the cumulative effect of mammography. So what do we at Breast Cancer Action suggest that we do in thinking about these guidelines? Well, the first thing we suggest is that a personalized decision about screening is always necessary. Risks and benefits will be weighed differently depending on individuals' risk tolerance, individuals' feelings about overtreatment, people's feelings about missed disease, people's feelings about convenience and anxiety. All of those things are very real, and those things can only be weighed at an individual level rather than at a population level. We also suggest that we need real investment in real prevention, and that while mammography is a screening tool for breast cancer, it is not a form of prevention. We believe that addressing inequities must be a central part of all work in breast cancer, and that we need to improve treatments so that people with the BERDs can have the same benefit that the people who have theirs now do. We also know that new research is necessary that includes this understanding of inequities. We need to think about the role of the environment. We need tools that can distinguish between birds, bears, and turtles. We need less toxic treatments. But you on this call may ask yourself, what can I do? I called into this call to find out whether I should get a mammogram, whether I should suggest it to my friend, whether I should stop getting mammograms, whether I should get them every other year. While I didn't give you an answer to whether or not you should do any particular thing, I hope I gave you some tools and some ways to think through the science to make a determination that is within the context of your values and your weighing of risks and benefits. We also hope that you'll sign up for Breast Cancer Action's e-alerts to stay informed about latest information about screening. We hope that you'll join organizations that support evidence-based approaches to breast cancer screening and think critically about who the organizations are and why they might be suggesting what they're suggesting. You're also often told to think and ask your healthcare provider about what you should do. But asking your healthcare provider, if your healthcare provider already has a specific answer in mind, doesn't get you the personalized approach we're looking for. So we encourage people to ask their doctor, I'm interested in your opinion, but I'm going to make my own decisions. And can you work with me to make sure that you identify a healthcare provider who's taking your values and your values and preferences into account? Do your own risk-benefit assessment. And most of all, we need to support other women's choices. As someone who chooses not to undergo mammography at particular times in my life, I would like to know that that decision is as legitimate as my sister who decides to have her mammography every year. These are individual choices, and women need individual support to make the best choice for them. And then, of course, I would not be a good board chair if I didn't say we hope that you will get involved in Breast Cancer Action. You will learn, you will share, and most of all, we hope that if this has been of any interest to you, you will consider donating to Breast Cancer Action. And I'm now turning it back over to Kim to close out this part of the presentation.
Thank you so much, Tracy. That was a really wonderful presentation, very informative. We know that there are some questions coming in. We will get to those in just a second. I just want to reiterate that Breast Cancer Action doesn't take any money from corporations that profit from or contribute to the breast cancer epidemic. So the individual support of our work is crucial. If you've been inspired today by this webinar, please consider making a donation of $25 or more so we can continue these webinars. You can go to bcaction.org and then /donate. So now we're going to go ask some questions of Tracy, and Alicia is going to kick it off. Alicia Harris, our program associate.
Thank you, Kim. All right, and just as a reminder, if you still have the question you would like to ask, you may enter the question in the questions box that you should see on the right side of your screen. And I'll start it off. So the first question we have here, Tracy, asks, what is DCIS?
Great question. So ductal carcinoma in situ. It is, while called a cancer, isn't yet quite a cancer. Does that help?
For some reason we're not addressing your question or it's not quite answered, you can always email us at info@bcaction.org. I think Alicia has several more that she's going to bring up now.
I do. Thank you very much. The next question is, can a turtle cancer turn into a bear cancer?
Yes, I mean, certainly the typology that I present is overly simplistic, and I think whoever asked that question, it's a really good clarification. It may look like a turtle and then behave like a bear. In this typology, we're trying to say that there are a number of cancers that, if left untreated, would not be deadly, but certainly something that looks like it would not be deadly may turn deadly, which is in part why we can't tell the turtles from the bears from the birds. And I think that's a really good question. This typology is sort of meant to create texture and complexity for breast cancer, but it definitely does not, no cancer is easily put in any bucket. And that's why something like DCIS, which we believe, in most cases is not deadly, but there certainly are cases where it is. So it's a really excellent question, and I hope a good clarification about the typology.
All right, thank you, Tracy. We have a couple of questions about thermography, so I'll just go through and make sure that I can, understand what all these questions are asking. So let's see. We have a couple of questions just generally about thermography, and also another question that asks if thermography would be a better solution for younger women.
Yeah, I mean, I think that the hope, of course, is that some different technologies will be better in certain populations. Right now, we don't have sufficient evidence on thermography to make any evidence-based recommendations on it. And I think that thinking through which populations it would be good for and when it is used in conjunction with other types of technologies. But I hope the point that I got across today was not that any individual technology is better or worse than another, but that they all suffer from the sort of same big problems that all screening technologies have. Thermography may, in fact, have some long-term improvements, but right now we don't have sufficient evidence to make evidence-based recommendations about it. I do know that Breast Cancer Action has some information on thermography on our website. And Alicia, do you want to point people there?
I don't remember where it is off of the top of my head, but anyone who has further questions about thermography and the information that Breast Cancer Action has, please send an email to info@bcaction.org, and we'll be sure to point you in the right direction. All right, let's see the next question. We have, in the United Kingdom, women are offered screening every 2 years starting at age 50. Do you know if mortality from breast cancer in that country compares to the U.S. data?
I think that and again, is a really excellent question. So different populations have different countries have different recommendations. It would be hard to compare the mortality rates in the UK versus the US because of all the other things that contribute to higher and lower rates of mortality. So you could conceive that if one had a higher mortality and one had a lower mortality, that it had something to do with screening, or it could be that one has better treatment than another. It could be that one has a population with less genetic risk than the other. So unfortunately, we can't compare across. What they tried to do in the U.S. Preventative Services Task Force is to pool that data to get some sense generally about what the benefit of mammography is. But we haven't been able, because of the differences across countries, to say whether or not one screening regimen is so much better because we have different countries with different screening regimens. But it's a really good question.
All right, and we have a few more questions. We have, let's see, one question asks, what would it look like to invest in real prevention? So it seems like so many things cause cancer. Do we need a new policy, education?
Great question.
That's a great question. I'm going to actually I'm going to answer it a little bit, and then I'm going to turf it to our prevention folks at Breast Cancer Action. So I think the first thing I would say is that it would start with us recognizing that mammography is not prevention. While mammography in the public health sense is a secondary prevention because it's trying to find disease before it's lethal, it is not in the sense of prevention because what you're doing is finding cancers as opposed to preventing cancer. So we would start by changing the way we think about prevention to think about breast cancers before they happen as opposed to breast cancers after they happen. And I don't know, Kim, do you want to talk a little bit about what BC Action is doing with regard to prevention?
Yeah, absolutely. I think there's a lot that's being done right now, and it's really exciting work. So one thing that we do is we support legislation that works to eliminate toxins in the environment that people are exposed to either involuntarily or even voluntarily. So an example of that would be recently the Safe Cosmetics Act of 2011 was introduced just at the end of June, and it would basically give the FDA, the Food and Drug Administration, a lot more power than it already has. It has very little power in the way of regulating cosmetics. So right now, if there's a cosmetic on the marketplace that has an ingredient in it that could be carcinogenic, the FDA has no recall power. But this legislation would change that. It would allow the FDA to recall dangerous products that are on the marketplace, and it would better protect people's health. So that's an example of some of the policies that Breast Cancer Action works to support. And we also really are big advocates of people getting informed about the toxins that are in other parts of your environment, so your workplace, your home, et cetera. But we also are recognizing the fact that this is a bigger than an individual problem. While it affects people individually, it is actually a societal problem, and we need to have systemic change, better protective policies that the government is regulating and implementing for everyone's health. Any more questions, Alicia, or do you have anything to add?
I think that was a great answer, Kim. There are a couple more questions, just going through them now. So the next question, let's see. There's so many good ones. Let's see. Okay, so here's one question. It says, when we talk about mortality, does that mean death within 5 years or death from that cancer in any time period?
Death at any time period. I think the 5-year mortality statistic is another one we need to do a little interrogation about. So we could and perhaps potentially have increased the 5-year survival rate in breast cancer by diagnosing more cancers that were never going to kill you. So we could, in a sense, you can drive down the ratio of death by diagnosing a lot of cancers you don't need to diagnose. So it can be very deceiving, that 5-year survival. Also, it doesn't, in breast cancer, the 5-year survival doesn't seem to have the same potential value that it does in other cancers. So surviving out 5 years doesn't necessarily mean that you won't be diagnosed or eventually die of the disease. And that, I think, has complicated the way in which we have thought about the value of screening. And so that's why that chart I presented that looked at sort of the flatlining of mortality over time gives us pause to think about whether or not our belief that a lot more diagnosis reduces the overall mortality. So it is dying of the disease at any point.
Thank you, Tracy. And
I think we have time for maybe one more, Alicia. Does that sound about right?
I think that sounds correct.
Okay.
So I have one more question here. This is a good one. So this question asks, where can we look for more general studies about radiation exposure and cancer risk?
We do have some information at Breast Cancer Action, and that's a place where, if you're interested in this, I would really recommend that you email Breast Cancer Action, and they can send you more information. It's very challenging, I just want to say, because there isn't, you're not just exposed through one thing. There's radiation, all kinds of cumulative radiation we have. But I'm pretty sure, Alicia, that we have some more information on radiation.
Yes, we do, in fact, have, I believe, a document on radiation as part of our updated screening policy that's on our website. In addition, I would recommend the work of Ellen Leopold, who is part of our screening task force, but does a lot of work and related to radiation and various health effects. All right.
Great suggestion. Well, we have, it's just about time for us to end here, and so I want to go ahead and thank you so much again, Tracy. We really appreciate your presentation today, and you've answered a lot of questions that I think many of us had. So we appreciate everyone's attendance as well, and if you have any other questions, anything that we didn't get to, please do email us. We'd be happy to follow up with you and answer it. Please do also watch your email for a short survey that we'll be sending you so that you can provide feedback on this webinar. We look forward to seeing you at a future webinar. So thank you very much, everyone, and good night.